What is Wallerian degeneration? Wallerian degeneration is an active process of degeneration that results when a nerve fiber is cut or crushed and the part of the axon distal to the injury degenerates. Fluorescent micrographs of Wallerian degeneration in cut and crushed peripheral nerves. Left column is proximal to the injury, right column is distal to the injury. Wallerian degeneration occurs in the section of the axon distal to the site of injury and usually begins within 24 to 36 hours of a lesion. Prior to degeneration, the distal section of the axon tends to remain electrically excitable. After injury, the axonal skeleton disintegrates and the axonal membrane breaks apart. Axonal degeneration is followed by degradation of the myelin sheath and infiltration by macrophages. The macrophages, accompanied by Schwann cells, serve to clear the debris from the degeneration. A 28-year-old woman comes to the office due to pain at a previous surgery site. The patient underwent cesarean delivery a year ago and had no issues with wound healing. However, over the past 2 months, she has had intermittent sharp and burning pain at the incision site. Physical examination reveals a well-healed, low, transverse scar. There is a small knot palpable at the left end of the scar, light touch of which elicits severe pain. Cutaneous sensory nerve injury and abnormal axonal regeneration are suspected. Sodium ion channels are most likely upregulated within the affected axons. Chronic axonal injury or inflammation, such as occurs with a neuroma, induces increased expression of voltage-gated sodium channels, which are important for the generation and propagation of action potentials. The density of voltage-gated sodium channels correlates with the excitability of nerves. Therefore, the upregulated sodium channels in injured nerves and neuromas increase nociceptive pain sensitivity. Neuroma is a benign growth or tumor of nerve tissue. To support the diagnosis of a neuroma, local anesthetic, which blocks sodium channels in the neuronal cell membrane, is administered to prevent depolarization of the nerve. This often provides immediate relief of pain. Action potential propagation depends on voltage-gated calcium channels in certain cardiac conduction tissues, for example, sinoatrial and atrioventricular nodes. However, peripheral nerve depolarization is driven primarily by sodium rather than calcium influx. The influx of negative chloride ions often causes hyperpolarization, which inhibits formation of action potentials. Magnesium selective ion channels are not directly involved in nerve depolarization. However, magnesium ions block calcium channels, preventing calcium influx at the axon terminal. This impairs release of neurotransmitter vesicles into the synapse, inhibiting impulse transmission. The efflux of potassium out of the cell leads to hyperpolarization. Therefore, upregulation of potassium channels would tend to keep the membrane potential away from the depolarization threshold, leading to less signal transmission, that is, less pain. A neuroma forms when regenerating axons are unable to find their distal target and create a haphazard mass of axons and supporting cells. Upregulation of voltage-gated sodium channels, which generate and propagate action potentials, is likely responsible for the increased pain of these lesions.